working as a senior resident at the All India Institute of Medical Sciences, New Delhi. And today I'll be presenting a paper titled Strengths and Limitations of Ceftazidime avibactam plus aztreonam combinations, and how it is time to move from an empirical therapy to a more targeted use. So talking about how we all know that how antimicrobial resistance is a major global public health issue right now, and as it jeopardizes the therapeutic potential of the modern medicine that we know of. And the major culprits of this increasing antimicrobial resistance is the MDR-GNB, or the multi-drug resistance gram-negative bacilli, as we know of. And the increasing resistance patterns in these bacilli have actually increased our dependence on the last resort drugs like colistin or polymyxin B and the novel beta-lactamase inhibitors like ceftazidime avibactam. But the inactivity of ceftazidime avibactam against metallo-beta-lactamases, however, limits the inclusivity of CZA in the Indian scenario, which shows an MBL predominance. So therefore, there is a combination therapy of ceftazidime avibactam along with aztreonam, which kind of has a synergistic action in vivo in the patient, is what is more recommended in such areas. Going about with the aim of the study, it was to ascertain the in vitro activities and the susceptibility profile of these last resort drugs like colistin and ceftazidime avibactam in a tertiary center with a substantial load of MDR and XDR gram-negative bacilli. And along with it, we were wanting to test the in vitro activity of the combination, that is ceftazidime aztreonam combination, using the recently recommended broad disk elution method by the CLSI 2024. So what we went about doing was we collected a total of 634 MDR-GNB isolates from a variety of clinical samples that were received in the microbiology laboratory of a tertiary care center in New Delhi, starting from December 2023 to July 2024. The species identification was performed by Malditov, whereas the antibiotic susceptibility testing was done by Kirby-Bow method, that is the disk diffusion method, or it was done by the Vitek-2 automated AST system. Isolates that were then resistant to at least 3 different classes of antibiotics were defined as multi-drug resistant isolates, and these MDR isolates were further tested for the susceptibility to colistin by colistin broth disk elution method and ceftazidime avibactam combination by broth disk elution method, both as recommended by CLSI. So you can see the 634 MDR-GNB isolates, as I said, were tested for colistin and ceftazidime avibactam, and the ceftazidime avibactam resistant isolates were further tested for the in vitro activity of the combination. So no growth in the tubes that were containing both ceftazidime avibactam and aztreonam discs were reported as ceftazidime avibactam plus aztreonam synergy positives or susceptibility. So as the results state, the maximum number of isolates that were obtained were from the respiratory isolates. About 13.98%, almost 14% were bowel samples, followed by mini bowel, endotracheal aspirates, tracheal aspirates. Then we had about 10% of blood BSI, or the bloodstream infection isolates, and 7.12% that were isolated from the sterile fluids. The susceptibility, the overall susceptibility percentage of colistin and ceftazidime avibactam was about 82% of the isolates were susceptible to colistin, while only 46.21% were susceptible to the ceftazidime avibactam. The table also shows a breakdown of the susceptibility profile of individual isolates, which were majorly including Enterobacter cloacae complex, Escherichia coli, Klebsiella pneumoniae, and Pseudomonas aeruginosa. All of them were the multi-drug resistant isolates. Further, the ceftazidime avibactam resistant isolates were, as we had mentioned earlier, we had carried about the in vitro synergy testing by the broad disk elution method, and the in vitro synergy testing of these resistant isolates. Klebsiella pneumoniae showed about 77.72% susceptibility to the combination, whereas Escherichia coli and Enterobacter cloacae complex showed only about 52% and 50% of the susceptibility profile, respectively. In contrast to these CREs, or the carbapenem resistant Enterobacteriales, we had the CRPAs, or the carbapenem resistant Pseudomonas aeruginosa, which showed about 91.09% of resistance or non-susceptibility to the combination, in contrast to what we saw in the CREs. So the crux of the paper is the non-susceptibility of isolates like Escherichia coli, about 50% of non-susceptibility to the combination, and almost 91.09% of non-susceptibility to the combination in case of Pseudomonas aeruginosa, whereas it is about 22.8% as non-susceptibility in case of Klebsiella pneumoniae. So as we can say, we cannot just go about with a blind treatment of patients for MBL predominant CREs or Klebsiella or carbapenem resistant enterobacteriales, because we can see there is a good chunk of isolates that do not actually have a synergy positive or a susceptible profile. So concluding the study, we could say that the present study brings forth an AMR pattern which is very diverging from the global trends in India. There was a high rate of resistance to colistin and ceftazidime avibactam, which on one end showed our dependence onto these last resort drugs, and along with it, it also showed how drastically we have diminished therapeutic options that are available for a successful cure of serious bacterial infections. And lastly, these increasing rates of resistance also necessitate the implementation of stringent antimicrobial susceptibility stewardship, antimicrobial stewardship and hospital infection control and policies to mitigate the crisis of MDR GNB and to conserve the last resort drugs for a better therapeutic success. Thank you.